All right, welcome back. My name is Chad Campbell. I am a certified functional medicine provider with Redesign You, and this month we are talking about heart health, and we have been joined by a very good friend of mine, Dr. Dave Johnson. Dr. Johnson has been a board-certified cardiologist with over 2 decades of clinical experience in the prevention and management of cardiovascular disease. In 2010, he completed the fellowship in integrative medicine through Andrew Weil Center for Integrative Medicine with myself. And this is where my amazing friend and I developed our relationship. Today, though, his passion is helping individuals find meaning in their symptoms so that meaningful solutions can be identified. His holistic approach embraces physical, mental, emotional, and spiritual healing. That is to say that the body, the mind, and spirit are inseparable, and each contribute to the balance between health and illness. Amen. Amen. Dr. Johnson currently practices in Traverse City, Michigan, where he has been developing a collaborative and multidisciplinary team that integrates the knowledge of conventional medicine with the wisdom of indigenous healing practices so that individuals become more self-reliant in overcoming their health challenges while achieving their health goals. Welcome, Dr. Dave.
Well, thank you, Chad.
So I want to do a little recap, if you don't mind. For this last month, we've been talking about this heart health. And in the very beginning, we kind of talked about how true, real heart disease tends to happen. And we had posted a picture that gave a new meaning to it, where the blood vessels actually were developing the plaque buildup in the artery walls instead of inside of the actual lumen, instead of the actual opening of that. Do you agree with that picture?
Yeah, absolutely. Most heart attacks don't occur because of a major blockage. Most heart attacks occur because of a vulnerable plaque that is usually less than 50%, often less than 70%, and often asymptomatic and until the event occurs, until the plaque rupture occurs. And unfortunately for many, that could be sudden death. And so that's why we've really kind of focused on trying to really not just treat the disease process after it unveils itself, but to help educate and support people with making the choices and giving them tools they need to prevent that vulnerable plaque from rupturing or developing in the first place.
So we kind of talked about where the scenario of inside of that plaque inside of that vessel wall would be dynamite. Mm-hmm. And then there was some type of detonator, something that irritates that in order to cause that dynamite to rupture inside of that artery, causing that heart attack or stroke. You talk about like the 70%, like what you had said, that 86% of those heart attacks have blockages less than 70%. And from what I understand with stress tests, that's what they can recognize is something that's higher than a 70% blockage.
Yeah, that's absolutely correct. The stress test is usually only done or should only be done to help diagnose symptoms, not to screen for heart disease. It's a very worthless test to screen for heart disease, yet it had been done for decades and used for decades for that purpose, but the data don't support it anymore. And fortunately, prior authorization has caught on board with that and really reduced the number of stress tests physicians are ordering, screening people for heart disease because it's inappropriate.
Yeah, I saw a statistic, I think it was last week, that had said that when somebody has had a heart attack, that the second MI, they showed that the LDL and total cholesterol really didn't have any effect on preventing the second MI. Mm-hmm. Have you heard that?
Yeah, I think cholesterol, well, there's two things I want to say. Going back to stress tests first. Stress test as a diagnostic tool for looking for coronary artery disease is not very good, but it's exceptionally good as a prognostic tool. In other words, if somebody does a stress test, a treadmill stress test, and they can go, 12, 14 minutes on a typical protocol, it doesn't matter what their imaging does, whether it's an echo or a nuclear scan, their prognosis is very good because they're physically fit. And we know that physical fitness, really protects the heart from events. Okay, so that's one thing I wanted to back up. So we do use stress tests from a prognostic purpose, not so much as a diagnostic purpose. And when we're talking about diagnosing coronary artery disease, that's one thing, but understanding what people's prognosis is another thing in terms of using testing. So I want to just throw that out there. But in terms of cholesterol, what we're learning is, there are an infinite number of ways today to look at cholesterol particles. Whether we're looking at just the lipid panel, the NMR, the particle size numbers, the shapes, structure, there's just so many different ways to look at cholesterol. And yet cholesterol is just one of the surrogate markers. It's not the cause for heart disease. It's a marker. And so if we just look at cholesterol and treat cholesterol, but we're not dealing with elevated blood sugars or inflammation or other, depression or social isolation, physical inactivity or poor diet, we're really kind of chasing our tail.
And I appreciate you said that about the stress test because, being in family practice, it's one of those things where you're saying, okay, every diabetic needs to continue to get this stress test every 3 to 5 years. Stress test comes back normal. And in family practice, it's okay, we're doing good, your heart's okay, and my whole thing is that all of these modalities are definitely, all of these types of things are needed in an individual patient. And my whole point with all this is that the best type of care for heart prevention is with the person who's sitting across from you. Yeah. It's the individual approach, and that maybe there's a lot of people who aren't on medicine and actually need to be on medicine. Yeah. Or there's also a lot of people who are on medication that don't need to be on medication. Yeah. Because we know that the risk calculators aren't as accurate as we try to do. Try to say. I wanted to tell you, some of the most common questions that we always get with heart disease is, am I at risk for a heart attack? Does my family history affect my health? What can I do to improve my heart health? Will it get better if I do all these lifestyle changes or these medications, or am I just doing it to prevent it from getting worse? And what exercise is the best? Those are a lot of the heart prevention questions that I get. Do you get similar questions?
Yeah. But I do want to go back to the stress test one more time because you're in primary care, so you'll get the reports, and I've seen this way too often, especially when it's combined with either an echocardiogram, an ultrasound of the heart, or a nuclear blood flow scan. And the scan comes back as normal, but the patient only walked 3 or 4 minutes on the stress test. Doesn't matter what the scan is. That patient is a very high risk for future cardiac events because of their poor exercise tolerance, even if it's a normal test. And so that's where it's a useful test, because you say, hey, we got to improve your exercise tolerance, but you need to do it carefully because you're out of shape. But right now we're not seeing any adverse markers. But know that a normal test isn't enough. You need to know exactly if they did do exercise, which is the preferred way of doing stress tests. It's much better than pharmaceutical induced stress tests because you can actually measure exercise capacity. And we know the best predictor for beneficial outcomes, in the stress lab is exercise duration.
What about those that aren't able to do the stress test?
Yeah, then you use the pharmacological stress test as an alternative, but you're not getting that same degree of information. And that's why it was developed, because people may have some EKG patterns or physical limitations that they can't do the treadmill test. And it's a reasonable alternative to assess symptoms, but not necessarily to screen for heart disease.
Okay. All right.
So let's go on to your questions.
So if we do take, let's take the some of these triggers first, and then we can get into some of the interventions and things that that you and I have talked about in the past. So when we talk about these, the dynamite or the plaque being inside of that vessel wall, and then we have these detonators. Some of the one of the highest detonators that I hear about and that I see in the research is insulin.
Mm-hmm.
Is high insulin levels. What would you say to that?
Yeah, I think, diabetes and, well, going back to high insulin is a pre-diabetic state, so you're overproducing insulin to try to keep your blood sugar normal. And a lot of people will have normal blood sugar, say less than 100, but have high insulin levels or high C-peptide levels, which is a better marker for insulin because it has a longer half-life in your blood. And so if you're producing that, that means your body's resistant to the insulin, and it's not, it's taking more insulin to get the same amount of glucose into the cell. And I've always liked Dr. Oz's analogy of glucose being like shrapnel in the blood vessels. If you have too much glucose, it's just going around and it's like shrapnel hitting the vessel wall, damaging it, setting up inflammation, and then the cholesterol leaks into the vessel wall along with white blood cells, and all of a sudden you start to get plaque formation. And we know from a microvascular, from the tiniest little vessels, that the time clock starts with the diagnosis of insulin resistance. That's when blood vessel dysfunction, and what we often refer to as endothelial dysfunction, or the abnormal functioning of the lining of the blood vessel so it can't dilate normally, that becomes impaired in that early phase of insulin resistance with high insulin levels.
Yeah, and with many people, when they go in and get those labs, if they are getting those insulin levels checked, they look at these A1Cs and say, well, I'm a little bit high, I'm not too bad. But some of the things that people don't know is that when the first thing to go up with our sugars is not our fasting sugar or our fasting insulin levels. The first thing that's going to go up is that fasting insulin level is going to go up 2 hours after you eat.
Yeah.
Then that sugar after you eat 2 hours is going to go up. Then the fasting insulin level, then the fasting sugar.
Yeah.
And in conventional medicine, we check, as a screening, we check the fasting sugar level, which is actually the fourth phase of this high insulin response. And so one of the big triggers, if a second MI, a second heart attack, is increased risk by 7 times with high insulin levels, this insulin is not the only thing, but this insulin level is a big factor that has to do with our risk for developing these heart disease and these heart attacks.
Yeah, it's incredibly underdiagnosed, and I forget the last numbers. It's like 81, you might know the numbers, like 81 million people in the United States have prediabetes or diabetes or something along that lines. It's an incredibly high number. So what I've done with my patients is if their blood sugar is above 80 or 85, I typically use, or their hemoglobin A1C is above 5.4, I'm thinking already that they're starting to develop some insulin resistance. And I do check insulin levels and C-peptide, but more often than not, what I do, I use that mostly to diagnose whether they have an autoimmune form of diabetes versus insulin resistance. And so I'm seeing a larger number of, we can talk about this a little bit later, about adult-related, latent adult diabetes, autoimmune diabetes. And because we're just seeing more autoimmune conditions, and that diabetes is one of them. But I just tell people, go out to Sam's or Walmart, get a Relion for $20. It's a glucometer to check your blood sugar. You get the lancets, the strips, and the glucometer for like $20. And you can check your fasting blood sugar, but you also check your 1 hour post-meal blood sugars and really see how high your blood sugar is going. And if it's going above 140, it's abnormal. If it's going above 180, then you probably need to be talking to somebody, about how to correct that problem. And I think most people don't realize how easy that is to do. And it's not done. You don't have to spend the money to do an oral glucose tolerance test. You can just do it at home. There are there are recipes like you can do an equivalent to an oral glucose tolerance test at home with, like white bread and banana and orange juice to get like 80 to 100 grams of, sugar. But I find it incredibly useful for people to see what they're doing in terms of their blood sugar elevation after a meal, because that's where the problem is initially occurring, is this high post-meal rise in blood sugar and insulin levels and triglyceride levels and everything else. That's actually causing the damage to the blood vessel. And you're absolutely correct. The fasting blood sugar may miss that, albeit most of these people will have a blood sugar, fasting blood sugar, typically above 85. And we know the risk for diabetes starts to go up, after a fasting blood sugar goes above 85, it begins to start to escalate the transition to prediabetes and diabetes over time.
Yeah, it's crazy. We're also a licensed diabetic center, and we had five of my patients that we put through a diabetic boot camp over the past five weeks, and without adjusting any medications until the very last night of the 5th week, I had to adjust some of the insulins. 2 fellows that were on insulin with averages of 220s, just within 5 weeks of dietary change and movement, dropped to averages of 110 and 133 on their sugars. And that's without insulin. I mean, without adding more or doing more. And then some of the ladies had these spikes these spikes that were going up after they ate, that then all they did was just change up their diet. And one lady, all she had to do was stop drinking the warm cup of milk every night that she had before bedtime. And they sat right down. And it was the most amazing thing, because they're thinking they're doing wonderful with their sugars. I'm thinking these insulin levels are doing really good, which also means that we're reducing this risk for all of this heart disease and these other complications.
Yeah, it's amazing how fast that works. I mean, think of, is it Gabriel Cousins down in your neck of the woods, who did this about 20 years ago? He has his own little compound where he put people on juice fasts and basically reverse their diabetes.
Yeah. Amazing. So if we think about that, I mean, and because many of these interventions seem to fall into multiple, whether we're talking about insulin levels, or we're talking about hypertension, we're talking about autoimmune disorders, many of them kind of fall into the same category. So if you don't mind, would you mind kind of giving us with the insulin levels, how is it as far as diet and intervention and lifestyle that we can help reduce those insulin levels to reduce those risks?
Yeah, so, there was a study, I think is now probably over 10 years old, called the Interheart study. That basically it's a multinational study published in Lancet. And what they came up with is they found that over 90% of first MIs could be avoided by lifestyle modifications.
Wow, that's a huge number.
Yeah. And so, they had their list of things, but it really boils down to, the 4 things that Dean Ornish talks about, and maybe a couple of others, So if you think about what Dean Ornish has published recently, ongoing, his initial publications were back in 1990, eat well, move more, stress less, and love more. And I would add in, sleep better or sleep well, and live cleanly. Know what your environment is doing to you, because we live in a toxic world, and there's a lot of environmental toxins that are playing havoc on a lot of people's health, in addition to lifestyle factors. So I really kind of hone in on what people can do for themselves through education and resources, from the lifestyle side of things to the environmental side of things. And then when I speak to them about the environment, I always say that there's 2 landscapes. There's the internal landscape of our psyche, and then the external landscape of the world outside of us. And so that's kind of how I approach prevention and reversal of disease in the patients that I see.
There's a lot of things out there that people will see, the listeners and stuff will see on the internet, or programs or things that are being sold. I just saw one from Hyman just today, a whole program that's being released on how to improve your health. And it seems like all of these things all come down to pretty much the exact same thing. As far as, just like you said, movement. It's not CrossFit, it's daily movement.
Yeah.
It's trying to stay away from the refined carbs and sugars, meaning trying to avoid the breads and the white rice and the pastas and the cereals, these things that have no fiber to them, and they just are processed very quickly and turned into sugar. So our body uses that instead of burning fat. And then the vegetable oils, it all comes down to these same things with the foods, and then trying to get you to sleep and stress reduction, trying to figure out how do you get that to blow it out, the Calgon take me away type of attitude, and to get some of that into our life every day. And there's a lot of different people that we could talk about in a little bit, if that's okay with you, about plant-based versus paleo versus keto. And we can talk a little bit about that so that people can hear our opinions on that. But don't you think it all comes down to kind of the same type of thing?
Yeah, it goes back, the stuff that Harvard put out not too long ago, what can make people live 10 years longer is eating a healthy diet, made up mostly of plants, but less of what you just talked about, which is mainly the processed foods, and fewer animal proteins than what we're consuming today, because our consumption has dramatically increased over time. It's getting 150 or more hours of some kind of physical activity per week. It's
50 minutes, right?
minutes.
Yeah. Wow, my goodness, you're a busy man.
I have my treadmill I'm on right now.
Oh, okay. Work and walk.
Yeah. And then maintaining a normal weight, and then what was the other ones? Alcohol in moderation is what they usually put. So it's usually those four things that they have. But again, I think they, the way they do their studies, I think they miss some opportunities to really emphasize, I think, again, sleep and stress, because I think those are a little harder to quantify in the databases that they have for that particular research, the nurses' health study and the physician's health study, that they've used that data for that information. But yeah, if you want to really hone in on the different aspects, I can't think of anybody who's phrased it more clearly than Dean Ornish and Eat Well, Move More, Stress Less, and Love More, And I think we live in a culture that's incredibly lonely, becoming increasingly more lonely and disconnected. Technology seems to be aggravating that to some degree. Human connection and connection with the natural world has kind of been significantly eroded over time. But at the end of the day, the one thing an individual can do is they do have control over what they put in their mouth. And so maybe the first place always for me to begin with people is, what are you eating and why, and how can we make some modification? Because that's vitally important, because it's the single most powerful thing you can do for your health.
Yeah. And do you think that with hypertension or even autoimmune disorders, that those all have the pretty much same template as far as the way to eat, the movement, all of those?
Yeah, I think unfortunately science gets a little reductionistic, so they miss the forest for the trees, so they hone in on specific diseases, whether it's autoimmune or or cardiac disease or endocrine disease or hormonal imbalances. And at the end of the day, it's all interconnected. And so, knowing what nourishes the body and its inhabitants, that's one thing we haven't really talked about, is the microbiome. Who's pulling the strings here? We think we're in control, but we have more, species that live on and within us than we have of our own cells, who actually maybe controlling a lot of the processes in our bodies, such as digestion and hormone synthesis and things of that sort. And so, that's where diet is so fundamental, because it connects the ecology of health through everything within and around us. And if we're just eating processed foods from, food manufacturers that have been denatured, heated to extremes and overly processed, and add in synthetic ingredients and increase shelf life, or add in synthetic nutrients, that's not going to nourish us as much as the food that grows on the earth, which has always been available to nourish the body, mind, and soul, and so we just need to learn how to get back to that.
Right.
Because the last 50 to 100 years, the dietary pattern shifts have so grossly shifted to an industrialized diet that people don't even recognize it. They have a hard time still. They think a plant-based food is something like beyond meat, which is a highly, another highly processed synthetic food, if you will, and versus, a salad and vegetables and things of that sort. So yeah, we have a lot of re-education to do because of both industrial and cultural adaptations that have really kind of shifted our lifestyle patterns dramatically.
Yeah, when we're talking about the microbiome in the gut, in my experience with my patients and my approach is, they say that we live off of the bacteria in us. It doesn't live off of us, like what you're talking about. And 10 times more signals going from the gut to the brain than from the brain to the gut. And if somebody wants to address heart disease or diabetes or autoimmune disorders, but they don't address the gut that's absorbing these nutrients to try to help them to recover from these things and prevent, then you're not addressing the problem. You're doing the Band-Aid theory to it. So addressing the gut first to make sure that we're absorbing those nutrients and absorbing the things that our body needs in order for it to function is of the utmost importance. And so just taking in whatever we want to eat and then taking a pill, we're not addressing the problem. And it is me too. I'm not going to be a hypocrite here. My big thing is Coke, like soda. It's just like sometimes you just want a Coke, and then I shouldn't even be saying this, but sometimes you just want a Coke, and that does not help my autoimmune disorders. I know that it does not help that. It aggravates those, but sometimes you just want those things. And so when we come to these people and we're talking about, okay, well, I want you to avoid wheat, gluten, sugar, dairy, corn, all of these inflammatory things, it is very overwhelming.
Yeah.
It's even overwhelming to me, and these are some of the things that I talk to them about. So what would you suggest to that?
Yeah, so it's really challenging. So if somebody comes to me and they're sick, they have autoimmune conditions, pre-diabetes, they have a lot of metabolic derangement. It's, you want to kind of start the process rather abruptly, in my mind. You don't want to go by the 5% rule versus somebody who comes in quite healthy. Yeah, they can, in terms of lifestyle change, they can slowly do the 5% rule where they make 5% adjustments at a time as they aspire to their health goals. But when somebody's already been plagued or challenged with medical or clinical conditions, then I often start to think about, well, how can we approach this in a more robust way? And so I will often do some form of a detoxification, an allergy elimination diet that involves not their typical one, because a lot of the allergy elimination diets still are fairly lean, animal protein heavy as a quote protein source, because people are just so concerned about not getting enough protein. Tell that to an elephant or an ape or a giraffe. They don't get enough protein because they're vegans. But at any rate, So I tend to put them on a program like that because it serves a couple of purposes. One is when you begin to transition a diet, as you probably know in your own practice, it changes the microbiome. You start to have changes in bowel patterns. You might get some unpleasant gas, bloating as the bugs in your gut are changing. And so using the allergy elimination diet is a way to kind of support that process in a way, while getting people familiarized with some plant-based recipes, so that when they transition back to a healthy diet, their next phase of diet, they have some background tools to use in terms of stable recipes that they can build upon. And then, when people leave, I have no idea what they're going to go home and do. But what my goal is to give them the information, give them the support that they need to be able to shift whatever their dietary pattern was before to something that's healthier, which, as you've already alluded to, means really two things. And that's reduction in processed foods, reduction in caffeine, reduction in alcohol, and increase in plant-based foods. And it doesn't mean that they have to become vegan or, become whole food plant-based, no oil, added salt or sugar type of thing, but they need to, try to get at least 80% of their calories, from whole plant-based foods. And then once they've achieved at least that, they're on a trajectory that's going to support their health. And then we continue to work with that, as a general rule. I mean, there are other patients, if I'm trying to reverse coronary artery disease, we'll shoot for that 100% plant-based, just because the data is so robust. But yeah, so it really varies. So I really individualize it for the person in front of me in terms of what are you experiencing, what are your challenges, and what are your resources? Do you have a backyard? Can you grow some food? Are you willing to do that? Are you in a food desert and don't even have fresh produce? Do we have to look at, buying, frozen or canned vegetables as an alternative to fresh produce? So we have to really understand where that individual's coming from, to kind of start kind of a prescriptive approach for them. Does that make sense to you?
That makes perfect sense, and I agree 100% that, and that's one of the reasons why I hope you feel like I'm jumping around, that it's kind of like people know about these risk factors. We know that smoking, too much alcohol, sleep apnea, weight gain, autoimmune disorders, high blood pressure, diabetes. We know that these are all risk factors for heart disease and strokes. The big thing that I'm hoping that we can do is we can help people to understand why just the simplest, smallest little changes are going to completely impact us. And that there's not one diet or meal plan that is going to be wonderful for everybody. We talked about, or you hear about plant-based, everything plant-based, plant-based, plant-based. And some people, they crave their meats. Some people want to have that meat. And so it's helping them to figure out what the meat options are for them. Some people, their heart disease is increased by meats. Like with this TMAO, where the bacteria is fed, which actually creates more plaque buildups inside of those vessels. And so when we talk about these different meal plans, the most solid thing that I have seen is exactly what we're talking about, is plant-based mainly.
Yeah.
Reducing the processed foods, reducing the inflammatory foods and the sugary foods, the dairy and these things which create high sugar loads. Not talking about fruits and vegetables. I'm talking about like juices and these other things which cause these sugar loads. And then choosing the right meats if those meats are going to be within your diet. And so, because the keto diet is huge. Yeah. I mean, it is huge. I'm hearing about it. I mean, patients want to talk to me about keto diet all the time. What is it that you tell your patients with the keto diet?
I say, open up another book.
Okay.
But the keto diet, the plant paradox, and the paleo diet are worthless because none of them are based upon any evidence. There's virtually no evidence, no long-term evidence. The keto diet, yeah, maybe if you have a childhood seizure disorder and you're in a hospital and
Because
you're,
that's how that was found. We would tell the keto diet for brain tumors in children and even some seizures
yeah,
with helping with epilepsy. That's the focus of that diet. That's mutated to where it is now.
yeah. But they've also, over the course of time, I thought I saw an abstract not too long ago where they tracked those kids down and they were developing, accelerated age-related disorders, which makes perfect sense because if you look at what's coming out of USC and Walter Longo's lab from, he's the person who created the fasting mimicking diet from Prolon. So he's been doing caloric restriction and fasting research for the last couple of decades. And so he's discovered, or his team and others have discovered what's called nutrient sensing pathways. And these are the pathways that are very vital for us to grow and especially for women who are in the reproductive phases to have children, that, like mTOR and PKA, and these are, growth factor things that help support the growing bodies or another body within. And it helps support men in their vitality to work in kind of a supportive role for raising a family. But after reproductive phases, those need to start to turn off. Otherwise, they start to stimulate age-related diseases. And now we have a diet that's high in sugar and high in protein, which are the two primary stimulants for these nutrient sensing pathways. And so protein is actually much more important in our earlier phase in life, not so much important in our middle life, and maybe a little bit more important in our elder years because of absorption issues and breakdown. But again, in the standard American diet, it's probably one of the most protein-rich, sugar-rich diets in the world. And yet we all know we have an epidemic of both not only obesity, but all these, non-communicable chronic diseases like heart disease and cancer and diabetes and dementia and things of that sort. And these are all age-related diseases that are accelerated. And so one theory is it may be related to these pathways. And if you can turn those pathways off, that's where the ketogenic diet is saying, well, we could just turn the pathway off permanently, but it's not a sustainable diet and people get sick over time. So that's where the fasting has come in, or at least time restricted feeding, where maybe you don't eat for 10 to 16 hours out of the day. So you start to turn those pathways off. And that's where the research is heading, is it's exploring these aspects of not only what we eat, but how we eat and when we eat is become vitally important. We have it, bleep backwards in this country because we eat our largest meal in the evening and not in the morning. And if we have plenty of data that show that if you eat the same, if everything's held constant, and you eat an item that has a certain fixed amount of macronutrients, including sugar, in the morning, and you eat that same item in the evening, right, your blood sugar rise is much greater in the evening versus the morning with no other influences. And so, so there's a lot of issues with eating that we have to address, not only what we put in our mouth, but how and when we eat. And it's very, very complicated. So, but to do that, you really have to know the individual and you have to work with them. That's why it's so vital to have really good health coaches that can help spend the time, because we as clinicians don't normally have that amount of time to dedicate to that level of care. And so having a team of health coaches who can really help individuals overcome those obstacles of making change is pretty key. And I think there's been numerous studies showing how that can be done successfully.
They're much more encouraging than I am. I can say that, where they continue to help encourage somebody to do it. One of the ones I read was the paleo. Did you say paleo as well? Is that what people call it? Paleo, this caveman diet.
Yeah.
And the big sell on this is, well, we need to go back eating what they were eating before. So we're going to eat this meat. But the couple things with that I would really caution people on is the meat that you're eating is not the meat that they were eating.
Yeah.
It was a very wild game that they burned calories. They would go fasting for days until they got their harvest there. For one, that, and then for the second, the exercise is not the same as it was then, and things have mutated as far as what they say that the paleo is, and so again, it's the individual approach. And even with this intermittent fasting, it's something that everybody should talk to their healthcare provider about, because one type of intermittent fasting is not always right for another. Sometimes people do need to do it during different times of the days, and some people can go longer times, up to 18 hours, where some can only do a 12-hour to a 14-hour fast. So make sure to get some guidance.
You don't want to fast if you're pregnant or lactating or have a significant medical condition, or even if you're a teenager, or if you've had an eating disorder, because it brings a whole nother dimension into, challenges with food. But going back to paleo, I agree with you 100%, because we don't live in a Paleolithic era. We have a country now in the United States where we've had 80,000 chemicals released into the land that have largely been untested, that, post-dated the Paleolithic era, that are, not only toxic to us, but toxic to the animals that we consume. And secondarily, you're right about the exercise. I've heard it reported that they walked an average of 25 miles a day. So just to justify eating meat. But I think to be truthful to the paleo diet, it's not that much meat that people think that it is. It's largely plant-based. It's over 80% plant-based. And if it's done according to what the researchers who created it studied, and so I think it's kind of misunderstood in the hype of what we can eat.
Yeah. So if we take all of that we've talked about with that, and we go to where the keeping it simple rule, we want to keep it mainly plant-based. I mean, that's what should be making up most of our plate. And a plant-based diet, reducing the processed foods, reducing the sugar, movement, as far as with our walking or some type of resistance training, sleeping good, loving more, and stress reduction. Pretty simple as far as a template for most of heart disease as well as the autoimmune. You agree?
I agree 100%.
Yeah. So if somebody was to do that and they're to implement those type of things, would they help reverse their heart disease?
Well, they could, certainly. I mean, we can certainly follow people along with various tests that you outlined in your last talk, to see how they're doing. And so there are ways to monitor, people and monitor their progress. I don't necessarily like tests I don't know if they're always the best motivator if you're motivating out of fear, because you fear what's going to end up in the results of your test. That's not necessarily good use of a test, like a coronary calcium score. But if a coronary calcium score becomes useful because it says, oh, now I have a score of X, Y, or Z, I really need to take this seriously, and I will, versus, oh, I'm going to have a heart attack because I have this coronary calcium score. So there's different mindsets. So you have to kind of deal with the different mindsets as it pertains to the testing material. And I deal with that a lot because I see people for second opinions because they've gotten the test done elsewhere and they bring it to me and they're, almost in a hysterical state because they're so afraid. And so I have to talk them down into a space where they can really be felt not only to be accountable, but empowered to make the changes that they need to make. And I'm here to support them. And it may need medication, it may need dietary supplements, but the core still are those, 4 or 5 things that you alluded to in terms of lifestyle medicine.
Yeah, and for me, I agree. The labs, it's not every lab is the same lab for everybody.
Yeah.
It's who that person is so that we can figure out what is that detonator that might be setting off that dynamite and how do we reduce that risk in that for them. So as an integrative cardiologist, what would be your advice as far as a health plan that people should consider on moving forward in prevention of their heart disease?
Yeah, so I'm really there's a couple of things that are happening right now. I mean, I really try to get people engaged into their why. Why are you doing this? Do you want to prevent heart disease to live longer, or do you want to prevent heart disease because you're just afraid of what's going to happen tomorrow because your great aunt died of 95 of a heart attack? What's really the underlying reasoning, for somebody to be concerned, so that we can use that and then also understand a little bit more what their aspirations are. What is it they really want out of the life that they have? Because that's what really kind of starts to hone in on to how do we set goals for that individual to move forward? How do you set the small goals, the short-term goals, so that they can live their long-term aspirations and purpose. And so it's not a one-size-fits-all, but again, I would typically engage people in conversation about a relational conversation, because to do it just for our health isn't going to be enough for most people. They have to have other reasons. So maybe it's to be available to their grandchildren or their children, or maybe it's they're concerned about maybe the environment and the changes in the climate as of recently that we seem to be experiencing. And so now we have really good information from reputable sources about how, for instance, diet can not only affect your health, but planetary health. The whole process that came out of Walter Willett's new group out of Stockholm called Eat Forum, which was published in The Lancet, really outlined, what would it look like for a modern day diet to reach and meet the Paris agreements for CO2 emissions in 2050. And it's largely a plant-based diet. It's almost a little bit stricter than a Mediterranean diet in terms of reduction in animal protein. So I gauge people with, not just looking at their own individual health, but the collective health as much as they're willing to go. Because I think adding in these other elements helps build that sense of accountability. And then now that you know that you can make small steps that help not only yourself, but the current, maybe even future generations, then it starts to carry a little bit more weight and to support the change. And I think that, again, the most vigorous way that we can do that is through our food choices. I made a quote the other day, I don't know if it's correct, but you can save CO2 emissions more by converting to a plant-based diet than changing from a car to a bicycle commuter.
I heard that today.
Yeah.
I heard the exact same thing today.
I said that 3 weeks ago.
Well, you must have been, I don't even know. And I think that is wonderful, because finding the why is what gives us our passion and our drive to not to just do something because I'm afraid that my chest is going to eventually start hurting, because 650,000 people die of it every year, but to think of, I'm doing this because of what's around me is very important. Yeah. And I want to enjoy that, and I want to be part of that. And I think that is,
yeah. And when somebody comes in and say, I'm worried about my heart and having a heart attack, one of the first questions I always ask is, when else has your heart been broken before? Because there's often something deeper, on the emotional side of the heart, because heart's more than a mechanical pump. It's the emotional center of the body. It's an energetic organ, you know, that sends electromagnetic frequency to the brain and other organs. So it has a lot of different functions. And, you know, we only seem to focus on the biological or functional heart as a pump with coronary arteries and electrical circuitry, but it's much more complex than that. And so you also have to deal with the psychosocial, spiritual aspects of the heart, because that's often, you know, at the basis of what a lot of people are really coming to you for, even though they don't know that.
Right. That's right. I can't believe it's already been 50 minutes.
Wow.
I know.
We haven't even talked about exercise yet.
My goodness. Yes. Exercises are mouths, I guess.
I think 100% of people don't smoke, you know.
That's right.
We forgot
So,
that one.
I want to thank you, Dr. Dave Johnson, for coming and spending time with us and giving us your expertise. And if anybody would like to get in contact with you, is there a way that they could contact you?
Yeah, so my webpage is davejohnsonmd.com, and you can reach me at drdave@davejohnsonmd.com.
Wonderful. Thank you. And if anybody is wanting to reach out and to look into Redesign You any further, redesignyou.net. My team and I would love to spend some time with you and see if we might be a match to help you reach your health goals. So next month, we're going to be talking about women's health. Dr. Dave, you want to come talk about women's health?
I'll pass. We can do part B of this, though. Because
we'd love to do part B. Definitely going to end up having you back for sure. And if anybody has any comments, any questions, please don't hesitate to comment in the comment section or to send us messages, and we would love to get into that conversation with you.
Yeah, and definitely watch Chad's last 2 videos as well, because it's a good precursor to what we just talked about.
Yeah, thank you. How heart attacks actually happen, and then the proper labs depending on the individual person in front of you. So thank you for joining us, Dr. Dave Johnson. Thank you so much.
My pleasure.
Stay warm over there, and we'll talk to you guys next month.
All right, take care.